Thank you very much. Is the microphone working? Yep, good. All right. So I very much would like to thank the organizers for inviting me and all of you for coming inside from the beautiful weather to join me for this. I'll try to make it interesting. Let me start by saying that unlike so many of the speakers that you've been hearing already, I am not much of a visionary. I like things very simple-minded. And the simple-minded questions that I've been wrestling with over the last 10 years have been, okay, we get all this exciting genetic and genomic information. How do we apply this to better human health? What are the nuts and bolts? Do we test everybody's genome when they're born? And if so, we get a long string of information and we get variants that suggest diseases, or we get variants that potentially suggest diseases. How in the world do we apply this? And when I say the future is now, I don't mean that these questions are solved. I mean that we and other laboratories and programs around the world are, ready or not, starting to apply whole exome and whole genome sequencing to the practice of medicine. Now, in order to do this, I think there are a variety of questions that we need to consider and we really need to think about, and systems we need to put into place in order to superimpose the use of genome sequencing onto our admittedly flawed medical system. And I'd like to talk to you a little bit about that today, using as an example my 10 years of work in something called the REVEAL study. And it's kind of funny because the REVEAL study is 10 years of work about the disclosure of one genetic variant. And here we are talking about disclosing all the genetic variants. So I like to joke that my career is now moving from studying the disclosure of one variant to the disclosure of all of the variants. And that seems like a nice leap. But nevertheless, that's what I'm going to take you through today. I'm going to talk to you about the questions that we have developed in thinking about a single gene variant and why I think it is relevant to the disclosure and use of whole genome sequencing in the practice of medicine. A couple of introductory slides. I'm very well trained in my country to make any disclosures. And unfortunately, I do not have any equity in any companies whatsoever, though I am open to that if any of you would like to offer anything. Let's see, does this change? Here we go. Yep. I'm primarily supported by National Institutes of Health and very grateful in particular to the National Human Institute for Genome Research, which is the group that has been supporting most of my work. The niche that I believe that I'm trying to develop and fill is a little bit of a new discipline in research. Obviously, I'm not the only one in this area, but the niche that I'm trying to define for the work I do, I'm calling translational genomics and health outcomes. And I will help you understand what defines this niche with a few questions. So if we think about the simple question, how should genetic risk information be communicated? This is quite a complicated question. In the tradition of medical genetics, we have very elaborate protocols using genetic counselors, pre-counseling before we give you the information, counseling after we give you the information, contextualization in terms of your family history. Clearly, this is not going to be very scalable when you're talking about many, many types of variants, all of which have different meaning. Other questions. If you give people information, particularly information they did not expect to give, and that's almost the definition of genomic medicine, is if I do your genome and I perhaps am looking for one question, I may discover several hundred other variants that give you variable information about your future health or your future pharmacogenomics. I'm going to give you a lot of information you didn't expect. There's been enormous amount of teeth gnashing and flagellation about whether this is going to cause anxiety, depression, worry, increased healthcare costs. This has been the realm of ethicists, and they've made many careers out of describing this. And I'm going to show you some data today to address all of this. But you know, at a more basic level, if we're talking about giving information to human beings, it may be important to try to understand what is it we say, what is it they understand, what is it they remember about what we say, do they distort it in their minds or not? What's the best way to give it to them, on a piece of paper, verbally, on an internet site? How do people perceive and work with information that we might give them about the genome? Just like a drug, I think of information just like a drug. And just like a drug can have benefits or side effects, I think we have to ask the question, does information, particularly complex information, have benefits or side effects? And if you think about it, that's a hard thing to study, but I'd like to convince you today that we've made some progress in studying this and in trying to begin to measure the health outcomes and downstream medical costs that will accrue when we have such information at our fingertips. And importantly, because this isn't all about the domain of medicine, what are the societal effects and what are the effects on such things as insurance purchasing and social relationships? Just as an aside, George Annis and I wrote an article a year and a half ago in New England Journal about what would happen in a presidential campaign if one side got hold of the coffee cup from another candidate and tested that DNA and then published all of the genetic risk information for all of the different diseases, and then tried to use that in a negative or positive way to support one candidate or another. And we speculated that it will not be very long before this starts happening in presidential campaigns. And at a lesser and less dramatic level, it could happen with corporate CEOs competing for the same job. It could happen in custody cases where one parent tries to get an advantage over another. You can almost imagine health information or information related to associations about psychiatric disease being used in huge variety of contexts. I myself look forward to the day I can walk into the health club, put my finger on the tiny little scraper, instantaneously read out not only whether my fast twitch or slow twitch muscles should be worked out that day, but with gene expression studies, exactly how many reps I should do. We've been also thinking about some things that generally don't get discussed in these contexts. What are the implications of negative genetic results? Let's say you have a family history of diabetes and you weigh 300 pounds, just to take an extreme example, and you take a genetic test, a commercial test or a test through your medical system, and it says, you know what, you don't have the genes that seem to be associated with type 2 diabetes. Well, obviously, that test is not being contextualized in terms of your family history and your own phenotypic risk factors. So what are the chances that people will misunderstand and say, oh, I don't have a risk of diabetes. Would you please hand me that extra jelly donut? And those are consequences which we're calling false reassurance. And I'm not sure whether those are important public health components or not, but I think it is a question worth asking. And that's one set of questions that we're asking. And again, very importantly, we are facing a situation where when you get your whole genome sequenced, you may be looking for one particular set of genes because of a phenotype that you bring to the table, but you will inevitably learn risk information about variable penetrance autosomal dominant conditions and reproductive carrier states and pharmacogenetic status that you did not expect to learn. Therefore, we are entering an era where there are going to be a tremendous number of so-called incidental findings that must be accounted for. And no one knows how to handle the issue of incidental findings. It is a topic of enormous controversy in the United States right now. I attended the World ELSI meeting. Most of you know that stands for Ethical, Legal, Social Implications of the Human Genome. And you could not go into a seminar without having someone agonizing about the issue of incidental findings. Do we have a duty to look? Do we have a duty to report? How extensive is that duty to report? Does it cover only actionable entities? Does it cover entities that occur in childhood, in late onset, and so on and so forth? It's a huge issue, and we have to grapple with it as we try to integrate these technologies into clinical use. So today I'm going to talk to you a little bit about what I'm calling component studies in translational genomics. And I'm going to wind up telling you that we're about to start the first clinical trial in the world where we actually study whole genome sequencing in human healthcare. But first, let me tell you about the REVEAL study, which I've been working on for the last 10 years. And this is, of course, a study about Alzheimer's disease. Alzheimer's disease is the most common cause of dementing disorder. It's an extraordinarily dehumanizing, devastating disease which robs you of your memory, your personality, and your very humanness as you age. And as most of you know, there is a polymorphism called ApoE, and if you have one copy of the E4 allele, then you are at increased risk for developing Alzheimer's disease, about 3 times the risk of someone who doesn't have that allele. If you have 2 copies of the E4 allele, you are at about 30 times the risk of developing Alzheimer's disease. Now, this isn't some odds ratio of 1.2 or 1.3. This is an odds ratio of 3 or an odds ratio of 30. So this is a real and substantive risk. On the other hand, Alzheimer's disease has no treatment and has no preventive treatment or strategy yet. Therefore, in the terminology of many people who speak about this, it is not an actionable diagnosis or an actionable condition to learn something about. Therefore, I find that some people are very curious and want to know, and some people say, I don't want to know anything about that. So let me ask this audience right now, you knew this was coming, how many of you would like to know your ApoE genotype so that you could have some insight into whether or not you are going to develop Alzheimer's disease? Okay, this is a very bold audience. I have a phlebotomist in the back of the room, and they'll be coming to get your blood shortly. Because you know what? In Huntington disease, they asked people how many people wanted to get tested, and it turned out that an order of magnitude, a lot of people raised their hands who were at risk, and an order of magnitude less actually stuck out their arm and got tested. So when we started this study, we were actually terrified that we had done surveys, and a lot of people said they wanted to know. We were actually terrified we wouldn't get anybody to volunteer. But we still thought this was a really interesting model, because ApoE can easily and accurately be measured. It's well documented to be associated with the risk of Alzheimer's disease. There's no treatments for this. And while that's a bad thing in the eyes of many people, it's a good thing in the sense that there were no market pressures, no pharmaceutical companies are advertising this to you. Nobody was sort of contaminating the situation, and remarkably, they have not been for 10 years. It's a terrifying disease. Those ethicists who argued from day one that it was unethical to share this information couldn't pick a better poster child for their points than Alzheimer's disease, and yet, as your hands just showed, people still want to know their risk. And it struck me from the very beginning that it was a little patronizing for us to say, we can tell you that, but we're not going to. We can tell you that information, but, and if you know the movie in the United States, you'll recognize this imitation, you can't handle it, right? Who is that? Jack Nicholson, right? Jack Nicholson, right? So that's what we're basically saying. In fact, there were 5 different high-powered consensus statements that had been written that said, under no circumstances, and I interpreted this personally, should me, disclose ApoE to unaffected individuals because there's no benefit medically, and all you're going to do is scare the bejesus out of them, and some of them are going to go up to the top of the roof and jump off, and it's going to be your fault. So this was not a very auspicious way to approach this, and in fact, I felt quite nervous trying to develop a research protocol. Now, we're sitting in the room today with 23andMe representatives and dynamic visionaries like George Church and Jamie Haywood, and people who have for years thought that this conservative stance was ridiculous. But 10 years ago, I was standing up in front of audiences, and people were standing up and screaming at me that even to consider this was absolutely unethical, inappropriate, and that I should have my license taken away. Nevertheless, I will give the NHGRI credit for funding this back in 2000, and they funded it, and what we proposed was a very carefully designed clinical trial in which we essentially randomized people to either receive risk information with ApoE genotype disclosure or to receive risk information without ApoE genotype disclosure. We tried to make the 2 arms as absolutely similar as possible. Now, there were a couple of interesting byproducts. The people who came into the study to learn their ApoE were really pissed when they found out that they were not in the disclosure arm. We actually had more dropouts in the placebo arm than we had in the disclosure arm. But anyway, we worked through that, and we did a trial which we published in 2009, and the bottom line of the trial was that as a group, there was no difference in anxiety, distress, depression, any of the issues people were worried about. Well, that was reassuring, but not completely reassuring, because really the question isn't, on average, do people do well? The question is, are there vulnerable individuals? And we looked at that, of course, in great detail. And the bottom line for this happens to be a depression scale score, and this is the percentage of cases, and this is in the group that did not receive any genotype, those who learned they were E4 negative and those who learned they were E4 positive. We basically found that, yes, some people did become more depressed as the study went on, but they did so for the usual reasons: money, love life, the economy. It did not seem to depend on what genotype they had found. And so the controlled study in this case allowed us to tease apart some of the anecdotal evidence that people had been accruing and say with a bit more confidence that under these carefully controlled circumstances, the disclosure of a risk genotype, even for a devastating disease, did not seem to provide harm for the individuals involved. Now, we've subsequently gone on to look at this in many, many ways. We've published several dozen papers on different aspects of this, and I'd love to share all those with you, but I'll just share a few highlights because of the time. Here's one thing that was interesting. Being a doctor, I guess I was under the impression that if I told somebody a number, a risk factor, they basically would believe me, right? I tell you, Effie, that you come into our study and I tell you, you take your ApoE and I tell you, okay, based on being a female and your age and your genotype, your risk of developing Alzheimer's disease is about 42%. And you go, thank you, okay. And I say, now, did you remember that number? And you say, oh yes, 42%. And I say, great. But then if I turn around and I ask Effie, what do you think your risk is of developing Alzheimer's disease? Turns out that almost half the time, Effie doesn't believe me. Effie has her own ideas about her risk of developing Alzheimer's disease. Turns out about 33% of the time, she thinks her risk is higher than what I told her, and about 14% of the time, she thinks her risk is lower than I told her. Now, if we hadn't asked, we would have never known, because people are very polite. They don't want to contradict you. But it turns out that people have a kind of anchoring concept of their risk. And it's based on many psychological constructs, somebody in their family, whether they think they're lucky or not. And it turns out it's actually quite hard to move this. And this may be a hint to one of the reasons why discussing genetic risk with people is not as psychologically devastating as so many ethicists were concerned that it might have been. I'm not making light of that. This is a genuine concern when you're talking about risk information. But if you already have an anchored sense of your own risk, it turns out that you can move it a little bit based on something I tell you, but it's very hard to move it very far. And so that was one of the insights of our study that I think helps explain some of the human behavior around risk appreciation and risk perception. Now, we also found that people value this information. They value it even though it's not medically actionable. Not everybody, of course. I've had many people stand up and say to me, I wouldn't want to know this. I wouldn't want to know this unless you could give me a pill that would stop the disease. I say, that's fine. But it turns out that the people who entered our study, obviously a self-motivated, self-selected group, not at all representative, but still, these people really value genetic information. And the people from personal genomics companies will be pleased to know that some people say they would pay over $1,000 just for ApoE genotyping. That's how invaluable they think it is. That's how valuable they think it is after they got it. Not beforehand when they were confused about what it meant, but after they got it and were completely clear on what it meant. So this is a sociologist's way of trying to measure value. And while there's a nice distribution, I think it's impressive that people attribute so much value to information that we in the medical profession say is valueless because we can't do anything about it. I mean, this really brings up a question of something we're calling personal utility. Here's another example of it. We asked people if they were more or less likely to purchase a product called long-term care insurance, which, as you know, is something that can help you out a lot if you develop Alzheimer's disease later in your life. And it turns out the people who learned they were E4 positive were 5 times more likely to purchase long-term care insurance than the people who learned they were E4 negative. Well, this was the first demonstration of differential insurance purchase that we were aware of that's ever been published. There have been lots of potential writing about this, that it could happen, it might happen. This was the first evidence that it actually does happen. And I remember going to the international meeting of long-term care insurance underwriters in the exotic city of Cleveland, Ohio, and sitting in a really generic ballroom with all these very polite underwriters in their Coke bottle glasses and their bow ties, and they're all sitting there very meekly and politely. And when I got to this slide, they all started shifting in their seats and turning red, and I swear to God, I thought they were going to storm the stage. These guys got so exercised about this result, they started standing up and screaming, "You're going to put us out of business." I'm going, me? Yes, you. And what they meant was, of course, that if genetic testing for this and other kinds of risk information, however modest the risk value, became ubiquitous around the country and was kept confidential so that customers could get a better sense of their own risk, then the playing field with insurance companies is no longer level. And the customer has privileged information. And under those circumstances, the insurance company either has to raise their rate to the point where it's completely unaffordable, or they go out of business. So this is an unintended consequence of personal genomic testing, and something I think we're going to be seeing played out in the coming years around ApoE and around many other risk variants. The question of actionability is also one that keeps troubling me. If you've been following the consensus statements, such as the FABSIT statement and the soon-to-be-published Susan Wolf statement, which I'm on the work group for, you will see that individuals, that these giant consensus groups like to say, we recommend that genetic information be returned if it is actionable. Okay, who could argue with that? That seems so eminently reasonable. But then here's the nitty-gritty. What the hell do you mean by actionable? Well, what I mean by actionable might be preparing myself emotionally. What most physicians mean by actionable might be giving a pill. What somebody who works in the arena of autism and mental retardation might mean by actionable is early stimulation of a child so as to minimize the long-term effects of the early discovered Fragile X syndrome or whatever. So within that very friendly word, actionability, I tell you lies a huge variety of opinions. And I think that the implementation of these consensus statements is going to be extremely troublesome. I'm thinking about trying to write an article called, and don't anybody steal this, called Against Actionability, where I basically say that the entire concept of actionability is so personal that it is almost meaningless to try to apply on a generalizable level. Here are people from our study who were told, we didn't think it was ethical to pretend to them that Alzheimer's disease was avoidable, so we told them right off the stop, there's nothing you can do. You know, maybe people can exercise, maybe they can eat a little better, but it's not proven. And basically, there's nothing you can do. And yet, the people who learned they were E4 positive tried to do things. They tried to do more exercise. They tried to take vitamins. They tried to do things. They were motivated. Somehow, surrounding the health outcomes associated with genetic information is this myth that has risen up and is incredibly ubiquitous when I go to genetics meetings, that genetic information never moves anybody's behavior. I just don't think that's true. I think genetic information has the potential to move people's behavior. And I think this is a wonderful thing if it's applied thoughtfully. Now, there could be a dark side to this. We found, for example, that people who learned they were E4 positive were more likely to go on the internet, and they were more likely to order non-regulated nutritional supplements. I don't know how you guys in Europe feel. I think there's a lot more leniency about these things here, but in my view, it's very clear-cut. Unregulated, uncontrolled nutritional supplements are highly fraudulent. They've not been proven to work. They have no value whatsoever. They are criminal, and in many cases, they do great harm. And so this poses a... Do you think I have a strong opinion about that? In many cases, I think this kind of information, in the absence of a rational response from the conventional medical establishment, has the potential to do harm for people who might be finding out about risk information. And I think we have to keep an eye on this. The other question is privacy. I also think that privacy is overrated. I'm actually convinced as part of this meeting, I've had my mind opened a great deal by some of the speakers, including Jamie, who's convinced me that some aspects of privacy may actually be immoral. But here's something interesting. If you want to keep your genetic information private, probably the number one thing is not to tell anybody. It turns out that despite our alerting people to this on the consent form, people go and talk about their genetic information. Just about their ApoE, 64% of people told a family member, all the way down to 12% of people telling their doctor. Now, we said in the consent form, if you tell your clinician about this, he or she may put it in your medical record where it may be discoverable by an insurance company who could then use it against you. They read that, they signed it, they still told their doctor. So I think we have to rethink what it means to try to create this culture of privacy around genetic information. And I think George Church clearly has been a visionary leader in making us rethink some of those issues. Now, many of you are familiar with the ACCE model for thinking about genetic testing. It stands for analytic validity, clinical utility, and ELSI issues. It's just a nice, convenient way to try to think about genetic testing. So in addition to this, we've been talking a lot lately about personal utility. Personal utility really isn't covered by this, but personal utility is what it means if you want to satisfy your curiosity, what it means if you want to buy long-term care insurance, if you want to share the information with your friends, your family, your doctor, your patients like me, community. So people find value in this umbrella term I'm calling personal utility. And although I didn't choose this slide to suck up to 23andMe, I have to say that I think that the example of Sergey Brin's use of his Parkinson's risk is a wonderful example of personal utility. Because here he found out he was at risk for something that we have absolutely no treatment for at this point in time. And what did he do? He turned around, stimulated research, poured funding into research, and may make a significant societal difference in this disease. All right, that's not a treatable outcome, but that's not nothing. That is action of a sort. So I think we have to become a lot less parochial. We in the medical profession have to become a lot less parochial about what we mean by actionability. We've done a number of clinical trials in Reveal in which we've looked at different things. I'm going to skip a couple of slides just to get to one that I think is a little more interesting for you, since I'm clearly running out of time here. Let's see if this switches. There we go. So you remember I made a big deal out of incidental findings. And the point about incidental findings, I think, is so important that we ran an entire clinical trial where we surprised people with information. So you came into the trial trying to learn about your genetic risk for Alzheimer's disease, but you got into the trial and, surprise, you learned something about your genetic risk for heart disease. And again, what we found is that it did not upset people anymore. They were not distressed to find out something that they didn't expect, which is good. I mean, they could have been. They could have been, hey, why did you tell me that? I didn't want to know that. In fact, they were pretty grateful. But more interestingly, they responded in a rational way in terms of a health outcome. So among the people who learned they were E4, the people in the yellow here who learned their cardiovascular risk was increased actually ended up doing more exercise. Whereas they didn't do that when they only learned it in terms of their Alzheimer's risk. So that's quite interesting and quite rational and quite reassuring that people learn these different risks and respond to them behaviorally in what might be considered a rational way. These are big studies to do. These are clinical trials. They're expensive. They are complex. They take a lot of statistical design work in order to make the results valid, and they depend on a great many people. In the final couple minutes that I have, I'd like to tell you about some new studies that are happening that are not about Alzheimer's disease, but which I'm very excited about, in which we're expanding our notion of translational genomics into other areas. And I'd like, as you see these, for those of you who are interested in research in this area, who would like to write papers in this area, who have students or postdocs or fellows, I'd love for you to keep us in mind and consider coming to visit with us, work with us at a distance, or send some of your students to work with us, because we're in the fortunate position now of having way more data than we can publish ourselves. The areas I would just like to mention that we're working in are these. Seems to be a tiny lag in the, pardon me? Okay, so one area is that we are studying personal genomics companies because we think this is a natural experiment in incidental findings. If you order your 23andMe or your Pathway genomics study, you may have one or two things in mind, but you get 100 different risk factors. That's all incidental information. So we have an NIH study that we're just beginning where we're going to survey customers when they order their test, but before they get their results, and then survey them after they get their results. And we have a complex way in which we will actually receive the same results that they see from the companies through a third party to maintain confidentiality. And so we will be able to ask for the first time, what is it these customers actually wanted to get? What is it they actually got? And what did they think they got? Because really at the heart of a lot of this is whether or not people misunderstand the information that they're receiving. We have an all-star group of people working with us on this, including some of the world's most advanced online survey experts, as well as wonderfully helpful representatives from 23andMe and Pathway. We're working with Catherine Wang at Boston University to do a randomized trial to see whether learning about genetic risk for obesity will influence the outcome of weight gain. Really simple question. Not so simple to do, but we think we've designed a protocol that will help answer that question. We're working with Richard Grant at Mass General to design a slightly more complicated protocol that has to do with whether learning your genetic risk factors for diabetes influences your compliance with an intervention program for diet and exercise. If that were the case, think how much public health good it could be to take people who are already at risk for diabetes, use their genetic risk to actually help motivate them to get better. Now, by the way, that dark side is still a possibility. So we're also looking at these people who are at risk for diabetes, but who turn out to have low genetic markers, and we're asking, are they falsely reassured? Are they disincentivized to participate in rehab programs? We're very proud to be part of the Gene Partnership that's being led by Zach Kohani and Ingrid Holm at Children's Hospital. This is the personally controlled health record in which a giant biobank is being constructed, and subjects are going to be given the ability to electronically tune which kinds of genetic results they would like to receive anonymously by computer and which types they wouldn't. This is the only problem I have with this is that most surveys, when you ask people what they'd like to receive, they pretty much say, tell me everything. So I'm concerned that in this study, people will choose to receive everything and yet will not be able to make sense of the huge torrent of information they might then receive. This isn't going to be an interesting struggle about this. I'm very proud to be playing a small role in George Church's Center for Excellence in Genomic Sciences, and as George may have told you yesterday, his group, among others, is working on interpretive mechanisms to try to work through the problem of variant interpretation. And finally, I'm on an advisory committee to the Coriell Personalized Medicine Initiative, and I like to show this slide because these guys, in addition to showing you some of the risk for, let's say, coronary artery disease that are associated with genetic variants, put on their output the same type of risk that you might see from smoking, from having diabetes, and family history, so that you can better contextualize your genetic risk. And I think this is an extremely important thing that the personal genome companies have not yet quite done. My final 3 slides, thank you, is going to speak to my title, which is the clinical use of whole genome sequencing. How are we going to do that? Well, I'm very happy to announce that a consortium of a group at Harvard is developing through the Laboratory of Molecular Medicine a clinical service. We have actually taken a great deal of our lead from the Milwaukee group that many of you know published one of the first studies where whole genome sequencing actually made an exciting clinical difference in a child with a terrible GI syndrome and may have saved his life. And we've just received 2 grants which are going to help with that. Ingrid Holm just learned last night that her R01 on return of individual research results findings has been funded. And we just learned last week that a brand new grant from NIH using whole genome sequencing for the practice of medicine will be funded. And our basic mechanism that we're going to try to do is for people who get whole genome sequencing for a specific clinical problem, we will generate a candidate gene report, and we will generate a general genome report with a specific set of clinically important incidental findings. And for those who go to their doctor and don't have a particular medical problem, we propose to generate simply the general genome report for all patients. My final slide is this, where I envision that the use of whole genome sequencing is actually going to require a system within the medical health system. It's not going to be done by just a bioinformatist. It's not going to be done just by a medical geneticist. It's not going to be done just by a genetic counselor. I envision that the physician is going to order these tests through the molecular diagnostic laboratory, that the bioinformatics interpretation is going to come back. It's going to come back through medical geneticists and genetic counselors to help interpret the more difficult aspects. It's going to be integrated with the electronic medical record. And hopefully in the future, in the same way that a clinician today doesn't have to understand pixelation, radiation, and spin cycles in order to interpret the report of an MRI, in the future, the clinician won't have to understand genome sequencing in order to understand and benefit from the interpretation of sequencing and all of the genomic gifts that will follow. Thank you very much.
Okay, questions, but we have to keep the discussion session maybe brief because we're running a little bit late, unless we can go towards the end a bit over time. So, please. There's already there, sorry. One.
Thank you. 2 years ago or so, you will tell me if it's correct, United States introduced a law to protect privacy in front of insurance. Tell me if this is correct and how it works. And I would be interested to hear your personal view on what should be done in this respect. Thank you.
Thank you. If I understand the question, you asked about the law that was recently introduced to protect genetic information. That's called GINA, the Genetic Insurance Non-Discrimination Act. And that law protects against employment insurance and health insurance discrimination. Interestingly, it does not mention long-term care insurance or disability insurance. Therefore, there are still some loopholes in that in the United States. But I do believe that that law was a good start. I think in general, it brought attention to the concept, and hopefully we will build on that law to be even more comprehensive.
Professor Green, thanks a lot for the talk. It was very informative. You brought up some interesting points, among which I was thinking of this pie diagram, where you showed the perception of the patients when you tell them of your diagnosis, so that you implied in a certain way that they have a safeguard mechanism against frustration after a diagnosis. Then a few slides later, you basically told us that that people react after they get the diagnosis and adjust their behavior. And doesn't this contradict in a certain point that people protect themselves by thinking, oh, no, I'm not affected, I'm of the good 40 or 50%, and then still react their behavior? So did you cross-link these information? Do these numbers work together, which you showed, or is there a contradiction actually at work?
That's an excellent and very sophisticated point, and I think you're exactly right. But I think it's sort of, what I'm trying to say is people have a buffer. They don't completely move in the direction of always accepting the information. But in a slide that I didn't show, we show that they do move somewhat. So I think what we've got is people moving their perception in a certain direction and acting on that movement, although not as far as we would otherwise imagine. If you give me your email, I'll send you the paper, which we've entitled, I Know What You Told Me, But This Is What I Believe.
and then one.
Thank you, Robert. Very nice talk, really. I have a question. I don't know whether you have data on that, but I would be also thankful for your prediction. For many complex traits, as more and more susceptibility genes are being identified, then the status of classification of a certain individual, which is classified now as, let's say, risk allele carrier, will flip. And might flip in the future. So there have been many studies showing that this is happening all of the times. With one variant, think you are a risk allele carrier. With 4, then you are more, let's say, on the protective side. How do people react to this? Do they then, let's say, think the value of genetic information is less? Do they, or is their trust the same as before?
Great question. I think that's absolutely true. Depending on which variants you select, and that's an ever-changing list, you can get risk estimates that are here or here or here. And that's caused some people to basically throw the whole thing out. They say, this is useless. It's completely changing. But I see it a little differently. I see this as we're very early in the notion that we need to transition our healthcare system from reactive to proactive. And we're early in the effort to build models for proactive risk disease. Now, what really we need to do is as these variants become discovered, I think this will settle down, and there'll be a set of variants that's generally accepted for each complex common disorder, and we will integrate family history, which is a proxy for unknown variants, and we will integrate age and phenotype and so forth, so that we will build overall better individual models for risk for any given individual. I think right now we're just very early in the process. And I had to answer a set of questions where there were a bunch of us answering a set of questions in print, and one of them was, do you think that this variability in estimate completely invalidates the use of personal genomics? And I said, no, I don't think it invalidates it. It just says we're early in the process.
Okay, one last question. Yes.
Thank you. Thank you. Your paper on in the New England on the anxiety before and after testing is very interesting, because it's the same story we had with HIV testing. And what it reveals is, in fact, that the doctors take for granted that the patient is anxious, and we have a very asymmetrical relationship with the patient. Now, this gene testing, like 23andMe, is an evident way to democratize. I decide as a patient what I want to do, if I want to do the test, and I come to see you afterwards and can you help me? And I don't need your help in the prime place to decide to do or not. But that changed very much the access to science. Because as a scientist or a clinician, we will go and ask them, do you want to participate? And they will choose yes or no. And I think, what you think, that will be a clear hint that this 23andMe way of selecting patients may be a very reasonable way.
I think that's a great point. And I think the challenge right now is that there's a huge gulf between highly educated, high socioeconomic, highly curious, tech-savvy, empowered individuals who want to get such information and dig into it and play with it and take responsibility for understanding it on the one hand, and less well-educated, less well-empowered, less autonomous individuals who are depending upon the conventional medical care system to help them understand what they should do about their health. And I think kind of being able to address this freely on both sides is critically important and a huge challenge. Thank you very much.
Thank you.